So today I'm very excited to have Hannah Ward with me. Dr. Hannah Ward, I've known for a few years and she works with me in my clinic, but she really is an expert, not just professionally, but personally as well, actually, with hormones, especially progesterone. And she's really reactivated a lot of work that we've known for many decades, led especially by Dr. Katrina Dalton in the 60s, 70s, and 80s, and it's been ignored. I was quite surprised yesterday. I put on a post about progesterone and cortisol, and it's very obvious when you know the pathways of our hormones, yet lots and lots of people really interested, overwhelming response. And even my husband, who's a doctor, was like, what? How does progesterone and cortisol link, Louise? I don't understand. And it's basics in medicine that we're often forgetting, and that's causing a real disservice to women's health. So we thought we would just take things back to a very simplistic way, and Hannah's going to describe more, but I think it might be worth starting off, actually, if you don't mind, Hannah, just talking about like your story, because we always learn, not just in medicine, but in life from our own experiences. And if you don't mind just saying a bit about what happened to you.
Yeah, that's right. And I never really thought much about hormones at all, Louise, until I had my children. And I had three children in my early 30s. And I felt really wonderful when I was pregnant. And I was, just sort of getting along with the stride. And then after my first daughter was born, everything was going really well for about 12 weeks. I was breastfeeding. Then suddenly I descended into sort of anxious insomniac that was quite depressed, and I just put that down to returning to work and tried to get on with things, and I just put it behind me and carried on. But every time I had a child, the same thing seemed to happen, and by the third one it just was so much worse, and I couldn't carry on doing what I was doing, and I had to do something about it. So I followed what I thought was the right path of action, which was to go on sertraline, an antidepressant, but unfortunately that just seemed to make everything worse. And I had recognized that this must be my hormone. I felt great when I was pregnant, terrible afterwards, and I started to research, and I came across the Association of Postnatal Illnesses, really helpful leaflet, and the first book on the reading list was Katrina Dalton's Depression After Childbirth, which I read in a day, and then decided, right, I'm going to be very naughty and prescribe myself for some progesterone pessaries, which I did on Mother's Day in 2010. And overnight, after one pessary, I felt back to normal. And I couldn't believe it. I thought, why didn't I know this stuff? Why have I never been taught it? And that really just was the beginning of my absolute fascination with progesterone and how I've tried to keep the interest going. But it just led to a big interest with hormones, but also PMS, PMDD, and menopause. I came at menopause really through progesterone, and now having been at the clinic for the last few years, we're starting to see younger women, and we're starting to give them progesterone and reignite Dr. Dalton's work. And for many women, it's really revolutionary for them.
Yeah, and it's such a shame. It's something that we're not taught at medical school. And in fact, for many years, I was taught progesterone is only needed if you have a womb to protect the womb from estrogen. And in fact, that is true, but the only bit is not true. So we do use progesterone when people are on estrogen, but most importantly, it is a hormone that is produced in different areas of our brain. And well, without a shadow of a doubt, the brain is the most important part of the body. So although we talk about progesterone being an ovarian hormone, of course it is produced in the ovaries, it's made in the adrenal glands, it's made in other tissues, but it is a neurosteroid. It's made in the brain, isn't it?
That's right. And it has so many other functions. There have been studies showing it's used in traumatic brain injury, recovery after stroke, that it's been shown to help with myelination, and perhaps it could be used for things like multiple sclerosis. And actually mental health, if you look deep into the literature, there are a lot of people who have used progesterone for mental health conditions in the past, because it's generally, for most people, calming. It works on the GABA receptors. It's an inhibitory neurosteroid, so it helps keep everything sort of calm and in check. But like you say, it's been vilified really, because we talk and think in medicine of the synthetic progestogens, the non-body identical ones, and they do not have the same neurosteroid effects, do they?
No, and that's really important actually to mention, because even things like certain contraceptives like the progesterone only pill, POP is often referred to by doctors. It's even called progesterone only, and it's not actually progesterone. It's a chemically altered synthetic progesterone. And that is so important that us as clinicians, but also women, understand the differences, because they don't stimulate the receptors in the same way and they don't work in the same way in the body. So the pure progesterone that you're talking about, the pessary that you had, was the same chemical structure as the progesterone you would have had in very high levels, really, when you were pregnant.
That's right, and that's really the basis of Dr. Dalton's work, that women produce masses of progesterone from the placenta, increasing right through to the third trimester, when many of these women who suffer with PMS and PMDD and postnatal depression actually feel at their very best. And then there's a huge withdrawal of progesterone and estrogen when you deliver a baby, and that withdrawing of the hormones could be one of the reasons that these conditions are triggered. But they're much, much higher doses. Even in the pessary, we know when you give some progesterone, either rectally or vaginally, you absorb 10 times as much as you do when you take it orally, because it isn't metabolized to the rapid action metabolites that a oral tablet of progesterone is. People think if you use it local to the womb and the vagina that it's actually not such a high dose, but actually you're absorbing more of it. It's just metabolized very differently because we have different enzymes in different parts of the body.
Yeah, and I didn't realize that actually initially, because I wasn't taught that. But obviously, anything we take orally, whether it's food, whether it's a tablet, whatever we put in our mouth gets metabolized through the liver. Liver's like a sieve, isn't it? And it can break down molecules, so it can break down progesterone into other forms, which some people find useful. But when it's given vaginally or rectally, it's using the mucous membranes to get into the bloodstream as the pure form. We don't have a patch of progesterone. There is a cream, but we don't have it licensed in the UK. So the next best thing is putting it in our vagina or rectum, isn't it?
It is, and actually, there is an intramuscular injection, but you actually absorb very well from the blood supply. There's a very good blood supply to the rectum. And I have to admit, I have used Cyclogest for 15 years, and I've only ever used it rectally, Louise.
But
So it can be a bit messy vaginally, I'm told.
yes, it's interesting, isn't it? Because, we're British, we don't like, anything in our bottoms. But if we were in France, there's lots of suppositories. It's a very good way of giving not just hormones, but medication in general, actually. But there's something that we've forgotten really over in the UK, thinking about prescribing. Some of you might have heard of Voltarol or diclofenac, and actually it's used a lot after operations. We often give it rectally rather than orally, especially if someone's feeling a bit nauseated. And it's so much better as a pain control, to control pain than orally, actually. But again, it's the same way. You're getting higher concentrations, you're getting the pure form in through the mucosa. And it's interesting because I worry a lot about the injustice of women not being listened to, not being believed, not being given appropriate treatment. But if we think about the pessaries, in the UK, they're often called cyclogest. They are used a lot in fertility, aren't they?
That's really nowadays the main use for them, actually.
So
So they're very safe. That anything's given when
yeah,
somebody's pregnant or trying to get
yeah.
pregnant is extremely safe. You wouldn't give a woman trying to conceive or in early pregnancy anything that had any sort of detrimental or what we call teratogenic effects. So we know they're absolutely safe,
Yeah.
but they're just generally only used in fertility at the moment.
Yeah, and that's because there's a lot of money in fertility, there's a lot more research, but actually, what we are forgetting is common sense. So, I've said when we are pregnant, our levels of progesterone are incredibly high, and then they fall off a cliff, literally, as the baby is born. But there are other times, aren't there, that we all have changes in our progesterone levels. So, I
Yeah,
don't know whether you
every
want to show
month.
your graph, Hannah.
So as we've all seen this picture before, Louise, I mean, it isn't to scale, which I'll show you in a moment, but you think of estrogen is in navy blue and progesterone is in green. And in fact, we do have a low level of progesterone in what's called the follicular phase and then the luteal phase. Sorry, I'm going to close my curtain because the light is blocking it all out. So on day 1 to 7, our estrogen level is low, and then the brain tells the ovaries, come on, get some eggs together. And it usually gets about 10 or 15, and they all produce a bit of estrogen. So estrogen starts to rise from day 7 of a 28-day cycle. And then one egg says, it's my turn this month to take over. I'm going to be the star of the show, the dominant follicle. And the egg pumps out increasing amounts of estradiol just up to prior to ovulation. And many women actually feel their very best in week 2, and they think, oh, there's nothing wrong with me. Life is great. They've got lots of energy. Their mood is good. They're sleeping well. And then just prior to ovulation, there's a surge of luteinizing hormone, a big drop in estrogen, actually. And that drop actually seems to become more of a problem as women get older and they enter the perimenopause. And then if they ovulate, the corpus luteum, which is the bit of the egg that sort of is released, produces progesterone, which rises, and also estrogen rises again until about week 3. So roughly day 21, everybody's a bit different. And then those hormones just turn down. It's like falling off a roller coaster, and women really notice the symptoms in that last week, the late luteal phase. And studies have shown that there may be various different types of PMS symptoms and timing of symptoms, but the majority of women really struggle in that week before the period and for a couple of days maybe afterwards. But actually that picture is not to scale, and that's because we measure progesterone and estrogen in different units. So estradiol, as you know, is measured in picograms or picomoles, and progesterone in nanograms or nanomoles, and 1 nanogram is 1,000 picograms. So if you produce about 2,000 or 3,000 picograms peri-ovulation, and you can see this big drop in estrogen there, we don't produce 2,000 or 3,000 nanograms of progesterone. We produce 40 or 50 nanograms, which is 40 or 50,000 picograms. And actually progesterone goes right up here and then really, really drops. And so you can't say that women who are struggling in the week before their period are sensitive to their own progesterone. They're sensitive to the fall in progesterone, certainly. And so giving progesterone back during this time can be really helpful and really effective, and that's what we're finding. But it obviously isn't the only thing that you can do to help premenstrual symptoms.
Absolutely, but in medicine we try and treat the underlying cause often, and so this drop. And what's very interesting is that we haven't got really good studies about all the levels because we're all different. If I did your progesterone level 20 years ago when you're having periods 10 times a day, I'd get 10 different results anyway. So it's changing, but also the level in our bloodstream is not always the same as what's in our brain and our other tissues. But we know that there are changes in progesterone, and some women are more sensitive, aren't they, than others to this change. And
Absolutely.
It's not so much the absolute level, it's probably more related to the drop or the change.
It's an abnormal sensitivity to normal hormone changes, because we all have these hormone changes if we're having a menstrual cycle, but only 35% of women will struggle and need to go to the doctor, and 5% they'll be severe enough to be diagnosed with a psychiatric condition, premenstrual dysphoric disorder. So they happen to everyone. It's just some women are very, very sensitive, and people think that's due to sort of imbalance in the GABA activity in the brain. They've got not as good production of serotonin, the antidepressant hormone. There are lots of sort of possible etiologies, but nobody knows exactly what it is. And I think if they did, we'd have a really, really good treatment, but we don't have a really good treatment, do we, Louise?
I mean, I think the problem is also it's been normalised so much, PMS and even PMDD, that you are going to feel bad. And just before we started this, I was just Googling some cartoons actually about PMS and PMDD, and it's always a butt of jokes, a hormonal woman, just don't talk to her, don't say the wrong thing, she'll be really touchy. But actually for that woman, there's lots of symptoms, and they are the same as the symptoms associated with perimenopause and menopause and postnatal depression, because it's the same cause. So a lot of people have symptoms affecting their mood, don't they? The low mood, the irritability, the reduced self-worth, the fatigue. But a lot of people also have physical symptoms as well. So they might experience muscle and joint pains, skin changes, hair changes, cystitis, and often not putting together the pieces, are they? Realizing that it's related to hormonal changes.
There's over 100 symptoms that you can
Mm.
have, but it's the timing and the severity that decipher whether that's a premenstrual disorder. I mean, men and boys and children can have the symptoms. It's just when they occur, how severe they are, and how much it affects your life. And like you say, it has been normalised, and people have just sort of got on with it.
Yeah, and Katrina Dalton was a real pioneer, actually. She qualified the same year as the NHS was launched, and she quickly realised there was a big difference between synthetic progesterone and natural progesterone. And she prescribed higher doses of progesterone, really to get the right amount for the right person, especially in their brain, to improve mental health. And she did a lot of people work with people with very severe postnatal depression and PMDD. Yet she had a lot of backlash. She was reported to the GMC. People tried to strip her of her license because they were worried about these so-called high doses of progesterone. And just to add, they are similar doses to the ones given to women with fertility problems. So they're not ridiculously high, but she knew, and she had a massive clinical practice, and women really flocked to her because they really felt so much better. And of course, it wasn't placebo, but she was also very ahead of her time because she talked a lot about nutrition, which is something that as doctors we often don't get taught about, or maybe in a 10-minute consultation as a GP we don't have sufficient time to talk about. But she was very clear, wasn't she, about lifestyle as well, and all this goes hand in
It
hand.
does, yeah. So she developed something called the 3-hourly starch diet to make sure that women ate regularly, particularly when they were taking their
Mm.
progesterone. Because, if you have low blood sugar, adrenaline can be released. This can block the progesterone receptor. It doesn't work very well. And similarly, if you're very stressed, your cortisol actually steals your own progesterone because it all comes from the same precursor. And so she said even just eating regularly can improve PMS symptoms for some women. And certainly this is a time when fasting is not your friend. So it's okay to think about intermittent fasting for the ways of eating, but actually in the luteal phase, your progesterone receptors need some carbohydrate. It needs regular blood glucose, and that actually not eating for long periods of time can make PMS worse. And I think a lot of young girls now are very conscious of image, and perhaps they don't eat regularly. We don't sit down and have family meals like we did. And just making some small changes as well as diet and exercise would probably make a big difference to a lot of people.
Yeah, so important. And some people, sort of, or need estradiol as well. Some people are testosterone deficient, and we've got a huge amount of clinical experience in the clinic. Like you say, we see more and more women, and a lot of time in medicine, you have the knowledge, the scientific knowledge. There's not good studies, but just because they haven't been done, there are a few that actually do show benefit. But we're noticing more and more the right hormone in the right way. Some people respond very well to oral progesterone, some better, like you say, to pessaries, some better adding in estradiol, and some women are testosterone deficient as well. But what I've seen over the last 20 odd years is that a lot of people are blaming hormones, which is the right thing because we've said it's a hormonal problem. So they're then saying, well, let's just switch off these hormones, let's just stop the hormones, and then everything will be fine. So people can have injections of hormone blockers, something like Zoladex, or increasingly women are having, their ovaries removed, their womb removed. But there are a couple of issues here. One is that the hormones are not just produced in our ovaries. And I've seen a lot of women that have had their ovaries removed and they're still getting symptoms because these hormones are produced in their brain, even in a cyclical way. But also, many of you know there are health benefits of taking hormones. So if someone has their hormones removed or a lot of their hormones removed, they're going to be at an increased risk of diseases like osteoporosis and heart disease. So how can we get around that, Hannah?
I mean, I think it's trying to look at all the different ways you can help someone when they're younger. So a hysterectomy, an oophorectomy or Zoladex is in the guidelines for PMS and PMDD. It is the fourth line. So it is the last and most drastic treatment. And, there are women who it may help and it may be an absolute wonderful resolution. But increasingly, we're seeing lots of women in the clinic who've gone through a surgical menopause and had their ovaries removed, and it hasn't been the answer. They haven't managed to get them onto the right HRT, and often they've needed to add progesterone in. But I think trying to get ahead of things early, so optimizing lifestyle with regular exercise. There are some supplements that can be helpful, so B vitamins and magnesium. Some women do really well on herbs. So Agnus castus has been shown to be really helpful, as has St John's wort. Obviously, these two herbs you can't take when you're taking the combined pill, but they can be really effective for a lot of people if they want to manage the symptoms on their own without going to the doctor. There are some guidelines, and the first line treatment is the combined pill. But as you have said, Louise, that blocks your own hormones. And so many of these women, sadly, don't get on very well with the pill because they are intolerant to synthetic progesterone, which is in all of the combined pills. There are some that are recommended to be better, such as the newer generation Yaz or Yasmin, or even the body identical Zoli. But I see so many women with PMS and PMDD. They've tried every pill under the sun, and within 6 months they got depressed, and it wasn't the answer, sadly, for them. And then they've moved on to other mechanisms like having some body identical progesterone, and that has been much more effective.
Yeah, and I think that's important to add. I'm going to go to some of the questions in a minute, but a lot of women I see, they say, I can't tolerate progesterone. It was awful. It was terrible. And often it's because they've been given synthetic progestogens or contraception. So we have to be really careful. There is a big difference. But also some people who can't tolerate or have side effects with oral progesterone, it's very different when it's used as a pessary, or the dose. So sometimes we give a higher dose. It doesn't work very long in the body. And so people sometimes have it 2, 3, 4 times a day, especially on those days where there's that big drop and their progesterone is very low. So the dose can change throughout the cycle as well, can't it?
So it's so important to individualise the treatment and take an individual history, because everybody is really different. Everything with hormones should be done for that one person, really.
Yeah, and it can take a little time as well. It's we have to we wait sort of a good 2 or 3 cycles before assessing whether there's a response. But some women, like you did, get a response very quickly, and then it's very easy for doctors to say, well, that's just a placebo. But actually, if we know how it's working biologically in the body, why is it a placebo? Why can't it just be that it's working and stimulating the receptors? So I think more and more we have to believe our patients.
We do, and there's one other treatment that can be quite helpful. So I see a lot of women struggle in the winter months, actually, and there's this overlap with seasonal affective disorder. There's a sort of shared polymorphism on the serotonin gene, and actually SAD lamps and light therapy, really safe, really effective, worth a try between October and March, can be really helpful.
Yeah, as well as vitamin D levels as well. Yeah. Really, really important. And really looking at having the right, vitamins, minerals, especially in our diet. And there is some evidence that women who take contraception have less, vitamin Bs, folate, iron. So we have to be looking, and that's something that's really important, is looking about all of these supplements. If we can get them from our diet, even better. But vitamin D is quite hard to get from diets, especially the winter months. Everyone should take a vitamin D supplement, and it can really make a difference with mood as well, actually. So all of these work together. Vitamin D is a type of hormone. Progesterone is actually derived from cholesterol. There's so much association, whereas so many people think they are just our sex hormones, and they are just from our ovaries, and they're just involved if we want to be pregnant, or for our periods. And it's very wrong to feel like that, isn't it?
Yeah, I mean, it's crucial in your bone health, your breast health, your brain health. As you've said, it all works in synchrony when it's working well. It's just that some people need a bit of support with their hormones if they're struggling with premenstrual symptoms.
Yeah, and certainly if anyone is offered or given an injection like Zoladex, or has their ovaries removed, it's certainly worth speaking to a specialist in hormones to talk about having add-back hormones, and we usually give them at a steady dose, so you're not having this graph that Hannah showed, and people often then often feel better after having their ovaries removed, but not fully better. And then it's often because of this big crash of hormones. So people can still have hormones back. It sounds a bit paradoxical if, you're having an operation or an injection to block hormones, but actually you're blocking that change in hormone
Yeah,
levels. So
yeah.
having hormones back at a steady state can often really make a difference.
Yeah, trying to even out those fluctuations. And sometimes we see that actually women need quite a high dose of both estrogen and
Mm,
progesterone, and that actually acts in a similar way to the combined pill, but
yeah.
with natural hormones. And actually, for those women, that works really well from them. But it does sometimes need to be quite a high dose to even out all that fluctuation.
Yeah. So there's just a few questions. I'm just going to just fire them at you quickly, Hannah. What dose of progesterone suppositories are needed during menopause? Well, I mean, we've already said it's individualized, but
Yeah, but I think a lot of the PMS patients need, 400 once or twice a day. That's
mm,
quite a lot compared to what people are used to giving,
yes.
isn't it?
Yeah. Someone said my partner still has PMDD symptoms and she's postmenopausal. Symptoms are still cyclical and is she on the right HRT? Perhaps not enough estrogen. She's on 3 pumps and 2 utrogestan.
Well, again, sometimes people still cycle after the menopause, even though it is meant to get better. I think that's due to the menstrual clock in the brain, and actually having a higher dose of HRT can flatten
Mm.
and even out those fluctuations again.
Does the dose of progesterone, pessary need to be doubled if using higher doses, 75 or 100 of estradiol?
Well, the pessaries only come in 200 or 400, so you're already using a higher dose. And actually, as we've said, we know we absorb more if you have
Mm.
rectal or vaginal, so you don't need to increase it, but you might want to increase it because that might help your symptoms.
Yeah, and we don't generally in the clinic knee-jerk increase one if we've increased the other because often people have a higher dose of estradiol to get adequate absorption through the skin. And we found from our studies and others as well that some people on a lower dose absorb better, so have a higher level of estradiol than others on a higher dose. So it's all very individualized. And like Hannah says, sometimes we increase the dose of progesterone not because of the estrogen dose, but because people need it.
Yeah, and you can be on progesterone alone. I mean, I took progesterone alone
Yeah.
for 10 years before adding back estrogen.
Because you were still producing your own estrogen
Yeah,
and didn't
yeah.
need it. Yeah. Someone said it's high doses of progesterone, also the best option for young girls, 20-year-olds. Someone has ADHD, gets very dark thoughts, or could estradiol, body identical estradiol, also help her?
Well, I think certainly for the younger girls, we often give progesterone alone first. And I know my daughter who's 20 uses progesterone alone. It does help. So that would be a good thing to discuss with her GP or
Yeah,
healthcare
and
provider.
sometimes they literally just have something like utrogestan, the natural body identical progesterone, for the second half of their
Yeah,
cycle, and that is enough. It can be
yeah.
transformational,
Or
sometimes
even for
even a few
7 days,
days.
just a
Yeah,
few days before your period is
yeah.
when progesterone's dropping. And then it's much easier to take something at that age if you're only doing it for a few days a month.
Yeah, absolutely, but definitely worth trying. Is it worth me trying? Cyclogest has bad reaction to 2 tablets progesterone, Jet protects orally or vaginally, nausea, migraine, detached, 1 tablet, okay.
Yeah, I would always try Cyclogest because progesterone is much purer. There are lots of other things in the tablets, aren't there? And it can be. I've seen a lot of women get on with it a lot better.
Yeah, absolutely. And there's a couple, or in fact, I think there's more than two now in the NHS of oral progesterone. So Utrogestan was the original one, then Gefpixarex, and they're supposed to be the same, but they do get absorbed in a different way. So it's the excipients that they're made and not the actual progesterone. So it's definitely worth changing a different preparation if you don't get on with something. Um, a similar query about my 19-year-old daughter who has autism, ADHD, suspect PMDD after 7 to 8 years, extreme mental health issues since starting her periods. GP mental health teams no help with this. So definitely worth speaking to a hormone specialist, isn't it?
I mean, she may well be able to try some progesterone quite happily,
Yeah.
but
My daughter's been on Marina Coil a year. She's 18 months now. Had helped her calm. So, I mean, some people find they have some benefit with Marina, but it is a synthetic
yeah, it's
progesterone,
probably
isn't
because it's
it?
stopping you ovulating actually for the first
Mm.
year, and then maybe you start to ovulate again and produce your own fluctuations. But
But people with a Marina can still have
They
progesterone as
can.
well as
Yeah.
estrogen and
Yeah.
testosterone.
Yeah.
And a lot of people think because they've got Mirena they don't need it,
No.
but actually
No.
it's very different, isn't it?
And estrogen HRT is second line in the guidelines after the combined pill. So having some transdermal estrogen with the Mirena is a very reasonable option there.
Yeah. The only other comments are all about the connection, and it's just because we're doing it live. Hopefully, when it's uploaded and goes onto
Okay.
YouTube, it will sound a lot better. So I'm sorry for those of you that are finding it difficult, but it should be fine when it goes up onto YouTube. So I hope you listen to it, enough of it to learn from it. Oh, just somebody's put here a couple more questions, and then we'll finish. Would GnRH be prescribed, so that's something like Zoladex, to someone as young as 19 when SSRI's Mirena pill therapy has not worked?
That you need to be referred to a specialist, a gynecologist in a special interest in PMDD who might consider that.
Yeah, but the thing is, if you haven't tried natural hormones, I would always consider natural
Yeah,
hormones rather than
first.
giving an injection. So certainly in the UK, if someone's in the UK, we see people in the clinic, the youngest age is 18, just for our insurance purposes. And a lot of times, once we start people on hormones and they're feeling better, then GPs take over their care. Because it's a lot easier to get something when you're feeling better and you're on the right prescriptions.
The trouble is, if you go on Zoladex, it then leads on to a hysterectomy, an oophorectomy, and that's very young, isn't it, to be
Yes,
considering that?
definitely. Um, do you have tips to prevent or stop severe menstrual migraines?
Magnesium's very helpful. Coenzyme Q10, progesterone, B2. So there are supplements that are evidence-based for
Yeah,
migraine that can really help. But so can progesterone.
as well as hormones.
Yeah, so Catherine Dalton wrote a lot about migraine
Yes.
and premenstrual migraine. So yes, that can be
And actually,
effective.
that's where she started to become interested because she found that her migraines disappeared when she was
Yeah,
pregnant,
yeah.
and then she linked it with hormones as well. So, extreme bloating and fatigue. Again, this is we're being very general here. There's lots of reasons why people get lots of symptoms, but again, we would always balance hormones first and then see what else is left in conjunction with, looking at your diet and lifestyle and everything too. Right. Oh gosh, the questions keep coming. So I'm just going to do two more. What is the cream I could use for frequent urination before a period? Started Everil Sequi patches 3 weeks ago and it's worse than before.
Are we talking some topical estrogen, perhaps, possibly, depending on, I mean, they sound like they're perimenopausal or menopausal, and maybe some localized estrogen treatment would be helpful here.
Yeah, so it's all about having the right dose as well. I have done a YouTube live about urinary symptoms as well. So, but you can have any type of systemic hormones, so including cyclogest, and have vaginal hormones as well, including progesterone, which converts to
Yeah.
estradiol and testosterone. Someone's got a sad face because she can't get cyclogest on the NHS. Um, and I do see this quite a lot in the clinic. And I think change will come. I think it's about educating doctors as well, because it is available on the NHS. Um, and it is maybe seeing another doctor and seeing if there is somebody else who can prescribe for you. The doctor wasn't happy giving progesterone because I have a Mirena. I'm in the menopause. Well, it's not really what the doctor, whether the doctor's happy or not. It's actually, it is just a natural hormone, isn't it?
That's right. Yeah. And we
So
see a lot
last,
more women taking additional progesterone with the Mirena coil now. It
yeah.
really helps sleep and
Really
anxiety.
makes a big difference. And
Yeah.
a few years ago, I didn't prescribe it because no one asked and I didn't really know about it. But it makes sense because it's just a natural hormone. So this is the very last question. I've heard that oral progesterone goes through the lymphatic system before it is made to allopregnanolone in the liver. Is this right?
I think she means goes through the digestive and the gut and then the liver
Yeah.
through the first pass. So not necessarily the lymphatic system, but it's broken down to allopregnanolone, but also pregnenolone, isopregnenolone. There's 4 pregnone steroids. None of us know very much about them, but they often can be calming or not calming in certain situations.
Yeah. But actually, fluid retention is a very common symptom of premenstrual syndrome and PMDD, and Katrina Dalton wrote about it as well. And that can improve with hormones too, concept of sort of bloating and fluid retention that can occur.
Progesterone is a very mild diuretic, so it helps
Yes.
helps you pee out a bit of fluid. Yeah.
So progesterone, the take-home message, is very safe, it's very effective, it's very different to any type of progesterone in contraception or the coils. And it's definitely worth going back and listening to my podcast with Hannah. I've done a YouTube just purely about progesterone as well. But the more that you read about it, the more you want to learn really, and more realize what an important hormone it is. So I'm very grateful, Hannah, for you joining me today,
That's
and I
right.
hope it's been useful for those people who have joined us and are going to listen to the recorded version as well. So thank you.
Thank you.